you want me to start, Anna?
Yep, I think it'd be great to start. Thanks, Graham.
So, just before we do start, I've got some echo. So just a reminder, if we could be on mute, that would be very helpful for the technology. Lovely. Thank you. Well, warm welcome from myself to the annual general meeting of Gloucestershire Health and Care NHS Foundation Trust. Those of you that can see the screen, my name is Graham Russell. I'm the chair of the trust, which is a great privilege for myself to serve the residents of Gloucestershire. And I'll just wish to make a few opening remarks just to set the scene for this our annual general meeting. So an annual general meeting is about reporting on the year since gone, so 2024 to 2025. But it's also a time to recognise the opportunities which our strong performance provides us as a provider of both physical health in the community and mental health services. As an NHS trust, we are very much values-led, and our values are the guiding stars in everything that we do. Working together to be better, always improving the services we deliver rather than sitting back, being respectful and kind in how we relate with each other, patients and partner organisations. And the fourth value is being driven to make a difference to the health of the residents of Gloucestershire. As a trust, we are both ambitious and innovative. An example of that, we shall hear more later about the new integrated urgent care service, which we launched in November 2024. We also receive good and positive feedback from people who use our services, and we shall also hear more about that later. And critically, we are a great place to work, the highest rated NHS trust in the South West as a place to work by our colleagues. We aim high. Our school-age immunisation service achieved the highest flu vaccine uptake for primary and secondary school children in the South West. We also balance the books and are financially sustainable, which is not easy given the increasing need for our services and the pressure on public funding. We have also reshaped the trust board with new executives and non-executives joining us through the year, and that's in order to provide the impetus and drive for further improvement in how we perform and deliver services. My huge thanks then to all board colleagues for the compassionate and collaborative leadership which you all demonstrate. Thank you. My massive thanks also go to all of the colleagues in the trust for your amazing service throughout the year and continuing, including those offering their lived experience, which is so greatly appreciated and valued. Also, massive thanks to the governors of the trust, many of whom are on this AGM call, who provide that critical link with the communities whom we serve. Massive thanks too to the very many volunteers who contribute their time and experience to make a huge difference to the experience of patients in all of our services. And also massive thanks to the League of Friends who provide such tremendous and huge support for our community hospitals and the equipment and facilities which we're able to provide. And massive thanks go too to our partner organisations who help us serve communities and also tackle issues which we could not do if we were working solely on our own. So with those opening remarks, just to say as well that we will take some questions as part of the AGM, but we'll take them towards the end, as you could see from the agenda that was the slide before this one. If you want to ask questions at that point, then you can raise your electronic hand. And also we have had some questions sent through before the AGM, and we will be answering some of those. So with that, so the format of the AGM is that with my opening remarks now done, I'll be passing over to the Chief Executive and colleagues in the executive colleagues from the board, just to give you a summary of the performance and achievements of the trust during the year 24-25. So with that, great pleasure to pass over to Douglas Blair, who is the Chief Executive of the trust. Thank you very much.
Thank you, Graham. And before I start with an overview of the year, can I just do a little bit of housekeeping, just to note for people that we have hit the record button on this session, just to be able to take a recording of the session. But also I've noted that we have an AI assistant that's joined for note-taking for one of our participants today. So I just wanted to flag that up to people in case there was any concern about that, which but particularly to make sure as people ask any question or make any comment, we will keep our content both suitable for the public realm and obviously if you want to share anything, be careful and in terms of if you're unhappy about things being recorded or being heard by an AI assistant from that point of view. So just wanted to mention that, and if anyone's got any concern, please do express that in the chat. So just wanted to say that before I started, but welcome to everyone to our AGM. So if we move on the slides, I just wanted to give a brief overview of the year, particularly we're talking about in terms of 24-25, but particularly just to start with a little bit of flavour about the types of activity that we undertake in Gloucestershire Health and Care. So in a typical month, one of those statistics that may surprise you, but just shows some of the kind of realm of services that we're responsible for. Our teams travel 300,000 miles in a typical month. That's because lots of our services are about delivering in people's homes and also just across what is quite a large county. We have about 17,000 calls to 111. In this year, we're talking about we became responsible for 111 in the county. So that gives you a sense of that scale. And in terms of our minor illness and injury centres across the county, there's about 8,200 attendances in a typical month as well, just to give you that sense of scale. There's a few other statistics there in terms of a number of sites we operate across the county, a number of kind of physical and mental health beds in terms of inpatient services, the referrals, the contacts across the year. We have over 6,000 colleagues, both in terms of substantive colleagues and colleagues on our bank, and 11,000 adults referred to our talking therapies. Overall kind of spend there of over £300 million in the year. And then in terms of one of the areas, particularly over the last few years, we've been focused on is our Young Minds Matter service that is around embedding support in schools. And we're covering over 60% of the county now. So that's about 58,000 school pupils are in schools and where we have a presence in terms of Young Minds Matter as well. So just a little bit of flavour before we started looking at the year in review, so to speak. So if we move on, in terms of the next slide, in terms of our service offering, you can see a range of different things, a range of different types of services, over 100 of them that we're responsible for, services across the whole county, maybe a small team, but delivering across the county. Our children and young people's focus, physical health, mental health and learning disability services, inpatient services, as I mentioned, as well as community-based services, and then urgent offer in terms of both physical health urgent issues and mental health urgent issues as well. If we move to the next slide, that means we're here really in particular different circumstances to assist people in staying well, promoting health, preventing illness. We mentioned immunisations, other things in terms of intervening as early as possible. We're here when people need some urgent care, particularly in their own home or in the community. So a range of different reasons that somebody might have an urgent need. We're here for people when you need treatment, both for a short-term issue, but also for ongoing and longer-term conditions as well. When people need to recover from a mental health or physical health issue as well, and also that ongoing support, particularly for people who are living with a long-term condition or multiple long-term conditions over the longer term as well. So a range of different reasons that our services in GHC exist, and there's loads more. Some of those examples there are mere examples against some of those particular things. There's lots more we could say on this slide as well. So we move on. Just to introduce you to our board. So I think if you came to last year's AGM, we were talking about last year being a year of transition. We had a few retirements in our executive director team, and also a few ends of term in our non-executive team on our board as well. So this year, we have kind of filled that team largely in terms of new executive directors joining us during this 24-25 year we're looking back on, and also new non-executive directors joining us as well. So this is the board overall. As with any board, it includes a mixture of executive directors, people who are employed to lead on certain aspects, whether that be a clinical leadership, operational leadership, or particular types of focus on our finances and our human resources or on our partnerships, and then non-executive directors that make up the whole board with the executive directors, and they are there to provide expertise, particularly from other things they're either continuing to do or have done in their past careers, and help scrutinise and hold to account in terms of the work of the trust as well. So that's the board as a whole. If we move on, importantly, to our values as a trust, so these are fairly well embedded. We've been doing some work, which I'll talk about later, in terms of looking at our overarching strategy. And one of the things we've been looking at is how well embedded and recognised are some of these values. And the answer we've had during these last few months is these are quite well recognised across the organisation now as well, because they've been in place for 5 years or so. So working together, always improving, respectful and kind, and making a difference. So those are things that we come back to, both in terms of how we appraise how our colleagues are performing in their roles, how we think about recruiting new colleagues, and also in day-to-day conversation about whether our values and behaviours are in line with what we would expect as well. So really, really important for us as a trust, as a conversation starter, and also something we come back to. So one of our favourite one is always improving, because actually that also keeps us on our toes all the time about where can we improve, what more can we do as well. So if we move on, this is one of those things that has a bit of a time lag. So every year that there is a national NHS staff survey, happens across every single trust, and it happens actually between just about this time of year. We have just launched this year's version yesterday, and that will be running as a survey until November. We then get the report of that in the new year, so to speak. So the one we've just started, will come out in 2026. So what we're looking at is the survey that was run around this time of year, autumn 2024, and was reported in the spring of 2025. And you'll see that in terms of that, one of the things we're pleased about is we improved our response rate again to 61%. So that's a relatively high response rate. We could always do more, but in comparison with other organisations across the NHS, that's a relatively healthy response rate. And we do lots of effort to persuade and encourage people to fill in the survey, tell the whole organisation what they think of working here. So you can see that. You also can see that in terms of our results, they are broadly compare well against the similar trusts. So we get compared against similar trusts delivering similar types of services across the country as well. So it's a good annual opportunity for us to say, what are our colleagues telling us in terms of how it is to work in Gloucester Health and Care, and how does that compare with similar organisations across the country? So you can see, I think, in all of those, we're above that average, or just at that average level as well. And then one of the particular headline indicators is people recommending Gloucester Health and Care as the place to work, and we have a healthy level of that as well. I'll come on to in a second. So we move on to the next slide. Little bit more information there. You'll see that in terms of the autumn 2024 results for our substantive colleagues, we also do surveys of bank staff as well. You'll see that the number of indicators that were in that top 20% when we compare with others, the middle 60%, and we did have a few indicators as we compare in that bottom 20%. So things that were particularly good in terms of our results there, that 76.3% people of colleagues saying happy with the standard of care for a friend or relative. 71.5% recommended as a place to work. Now that's a positive position to be in relative terms with other organisations in the NHS. But one of the things we continue to say is that does mean if you take that round, that means over 1 in 4 people are not recommending as a place to work. Comes back to that always improving. What more can we do in terms of that? And an 81%, 0.2% agreeing that care of patients and service users is the organisation's priority. But as I said, there's plenty more to do, lots of areas of focus, particularly around harassment, discrimination and violence at work. Sadly, a trend within most trusts, but something we really want to focus in on as much as possible. Colleague engagement in change and also speaking up. The management of conflicting demands and time, teamwork, and how well we're doing clinical supervision as well. So particular areas of focus. So a survey we always encourage colleagues to be honest in and to respond to, because it does help. Just do that test every year about where we could get better and different things we could do as well. So if I move on to the next slide, just wanted to take a moment just to celebrate a few things looking back over the last 12 months. Also, we've had a survey of users of our mental health services. That's done by the Care Quality Commission. And we were told during this period that we were in the top, one of 4 trusts across the whole country whose results on that survey were seen to be better than expected. So that was a positive position to be in. I mentioned that we'd taken on, and I think this may come up later in the presentations, but we took on a service which included responsibility for 111. So you can see, and this at times, we're quicker than this even than March, but in March, which is a few months after we took the service on, you can see our call answering time for 111 using our partner, IC24, who are a social enterprise. They're responsible for the 111 service. But you can see the response time was much better than the previous March before we became responsible for that. So that's shows some of that improvement. Graham's already mentioned some of our school-aged immunisation service performance. We're pleased to be re-accredited as a veteran-aware trust during this year as well. And in the PLACE assessment, which is patient-led assessment of our care environment, we're above the national average in the vast majority of areas in terms of our quality of the estate that we're responsible for, and the cleanliness of it and the state of it as well. So pleased to see that as well. My last slide here is just to do just concentrate on a few things that we're particularly focusing on at the here and now. So particularly focused on things like our length of stay, particularly both across our physical inpatient services, that's how long people are being an inpatient, and also in our mental health services as we look across the national average. There's lots of improvement work there across the region as well we're participating in. We've got reviews ongoing with partners across the system about how our learning disability services should operate in the future. We continue to improve some of the support for hospital discharge from the acute hospital. We have a service called Home First and use of our inpatient beds there. We're focused on transforming care digitally. One of the big 3 shifts being talked about in the new 10-year plan that was published a few months ago is analog to digital. So we're playing our part in that. We're focused on the transition of some of our existing services to Gloucestershire County Council, who have a new model of social care. So we're focused on that at the moment. And again, an ongoing focus of recruitment and retention, which has improved, but actually we keep on focusing on that. And as I mentioned, there was a national 10-year plan published in July, which sets out a range of priorities for the NHS. So again, we're focused on how we play our part as a trust in there as well. One of the things I also mentioned a few moments ago was we've been looking at our overarching trust strategy. Our existing one was running into 2026. So it's something we want to refresh and need to look at what it needs to be and how we set that strategy for the future. That's something, a bit of activity, including some public engagement over the summer, we've been focused on. So that's likely, it's going to come to our board at the end of this month in terms of the streamlined and very focused kind of set of high-level plan in terms of what we want to focus on in the next 5 years. So that's hopefully going to be signed off at the end of this month. And these are some of the areas that we expect to have as areas of focus within that strategy. So you see that local neighbourhood connecting up, one of the things that's set out. You may have heard some announcements from the government during July about a neighbourhood health service. So we're really thinking about what that means in Gloucestershire, really putting our focus around children and young people at the centre of some of our planning there, and also our support for when people have urgent healthcare needs, and also importantly how we make more inclusive healthcare, how we reduce some of the gap of experience and outcome there, and also importantly how we deepen some of our partnerships with other organisations across the statutory public sector and also the voluntary and community sector as well, so that we can do a better job together in terms of meeting the population that we serve as well. So a range of areas of focus that are likely to come into our longer term planning as well. So I've given you a bit of an overview of the year in review, what the board looks like, what our values are, how that results from that staff survey, where some of the areas of particular achievement, some of the things we're focused on at the moment as well. Hopefully a helpful kind of overview for this year. And at this point, I think we're running slightly ahead. So Graham, just to take the
yeah, you can pass back to me, Douglas. That's fine. Thank you. Thank you, Douglas, for that overview. And just to remind people on the call that now on our website is our annual report and accounts. So that will give you a lot more detail of all the points that Douglas has summarised there. So I would direct you in that. I think if you were invited through an email which you received, you'll see the link is embedded in that email. So please follow that. And there's also a very short film which summarises the year for Gloucestershire Health and Care Trust, and encourage you to look at that and to share that with any colleagues and neighbours and friends that are interested in how health services are provided in Gloucestershire. So thanks again, Douglas. Well, let's. I mentioned earlier that we were balancing our funds, and yet there were pressure on those funds. So let's just look then at the financial performance and accounts. And great pleasure to hand over to Sandra Bettany, who you can see is the Director of Finance and the Deputy Chief Executive Officer. So Sandra, over to you. Thank you.
Thank you, Graham. So I'm going to go through the accounts line by... No, I'm only joking. Not going to go through the accounts line by line. I'm going to do a quick overview of the accounts, and I'm also going to touch on some of the areas of financial performance and also how we spend our money. So if we just move on to the next slide, please. Thank you. So the first thing to tell you about is where we get our income from, and you'll notice that there's a really large section on this chart where we get £270 million of our income from integrated care boards. That's plural, but most of it actually comes from one integrated care board, which unsurprisingly is the Gloucestershire Integrated Care Board. We do, though, get money from other areas. So we get money direct from NHS England nationally. We do get money from other providers to provide patient care, particularly through provider collaboratives. We get money, as Douglas was mentioning, from local authorities for patient care. We get specifically funded for education and training, as well as some income that we make from non-patient care. So it just gives you a bit of an idea about where we get all of our money from before I start talking about how we spend it. Move on. Thank you. As you'll see, the largest portion of this chart is what we spend on salaries and wages, closely followed by social security and pension costs. So if you take those two together, it's pretty much 3/4 of the chart. We do buy some healthcare from other organisations, including private providers, independent providers. We then obviously spend money on supplies and services to provide clinical services, as well as non-clinical supplies and services. Premises makes up a fair amount of our costs. And then there's depreciation and capital charges. So depreciation is the amount that we charge to our income and expenditure as a result of owning assets, and capital charges is what we pay to the Department of Health for the privilege of having the capital to spend on those. You'll see there's an amount called impairment. I'm not going to explain that now because I'll do that later on in the presentation. Thank you. we can just thanks. So just in terms of the expenditure by directorate, this is how we organise our operational services, although you'll see that we've got estates and digital services and corporate services in separate sections on here. But you can also see how it breaks down into the individual directorates. Obviously within those directorates there's individual services, but you can get a broad idea of the split between mental health and physical health, although some of our directorates are actually integrated directorates, such as county-wide services and adult community, as well as children and young peoples. But that just gives you a broad idea of where the money actually goes that I talked about on the income slide. Just move on, please. So we met our financial performance target of break even, although if you look in the accounts, you'll see a very big scary deficit number, and I'll explain that in a moment. But our reported performance surplus was a surplus of £310,000. We also delivered just over £11 million of capital projects and achieved £5.4 million of recurrent savings, which is really important. When I say recurrent, it's savings that we expect to be able to make every year. We ended the year with a healthy cash balance of 41.8 million, and that equates to a liquidity ratio of working capital of 28 days. So liquidity is how much have we got at our disposal to pay our bills. And what 28 days means is that we can pay 28 days worth of expenditure with the working capital that we've got. Working capital is cash, plus things that we can easily convert into cash. So that's a pretty healthy position for an NHS trust, because we don't make huge surpluses, as you can see from the surplus there. I'll explain a little bit about the difference between our performance surplus and our actual surplus, in case you've been looking at that in the accounts, in a moment. If we move on, please. So just before I go on to that, you can just see what's happened to our income and expenditure over time, and you can see it split down into the different categories there on the graph. And then you can also see it split by type of services. So we've got mental health, learning disability and physical health services split out what proportion of the spend they actually are. But you can also see our income, and you can see that pay pretty much mostly tracks income. That's because most of our income rises are because of pay rises. So as pay rises, we actually get more income funded from predominantly the ICB. You can see that the non-pay is a slightly flatter line, and the capital charges that I talked about earlier, the public dividend, capital and depreciation, that's a very flat line, because that's actually the assets that we've got available. If we just move on, please. So this is the slide that explains what you see in the accounts compared with that 310,000 performance surplus that I talked about. So we actually had a deficit of 4.3 million, but that 4.3 million was actually caused predominantly by changes in valuations, which is what impairments are. So basically, if we decide that our assets that we hold, so mostly buildings, although not exclusively, in the current market would cost less to rebuild currently, because that's the way that we actually work out the modern equivalent asset valuation, which is what we use in the accounts. Then we actually devalue those assets, and that affects our I&E. So 4.4 million of the 4.3 million was because of that accounting treatment. As you can see, if you look at the previous year, it doesn't happen every year, but when you look at 22-23, you can see that sometimes it has a really big effect. So a moderate effect this year, but obviously it's a big part of the number that we report in the accounts. NHS England doesn't count that as part of our performance, because it's simply driven by usually the markets in terms of what assets are worth in terms of rebuilding and land assets, etc. Then we've got depreciation on donated assets, which is part of our I&E, but it isn't counted as part of our performance because they're assets that are donated to us. And then we have this weird line at the bottom, which is the net impact of consumables from other DHSC bodies. That was to do with when we were given protective equipment during COVID. As you can see, the number's been coming down, and next year you'll see that that will be a zero number because we aren't receiving any deliveries of PPE anymore. Bren's just asked in the chat, good question, Bren. DHSC is the Department of Health and Social Care. I do apologise. You do well to pick me up on the jargon. I do try and avoid it, but that one just crept past. Sorry about that. So that's how you can see we get to the adjusted performance surplus. If we just move on, please. This is what I was talking about in terms of the capital. So we spent just over 11 million. And you can see what we actually spent it on. So we spent it partly on buildings. We did a big part of maintenance. That's mostly backlog maintenance, so maintenance that's overdue. Quite a lot on IT infrastructure and software to keep things up to date. Fair chunk on medical equipment, you can see in the purple box there. And we did invest quite considerably in net zero carbon projects as part of our commitment to sustainability, as well as some new leases, which also count as capital. So that just gives you an idea about how we spent that 11.8 million. Just move on, please. One of the new services, and Douglas mentioned it as part of his presentation, was the Integrated Urgent Care Service, which was launched in November 24. Just to tell you a little bit about it, Douglas already mentioned that it provides the NHS 111 service for Gloucestershire. It also provides a new service, which is a clinical assessment service, which is gives access to specialist clinical advice, and we provide out-of-hours face-to-face care with clinicians seeing patients both at treatment centres and in their own homes. So that just gives you a little bit of an idea. You can see in the logos at the bottom the three parts of the Integrated Urgent Care Service. That's why we call it the integrated service. And you can see the day we launched, there was lots of snow. You can see in the photo. It's possibly the best launch day ever. Just to give you an idea about the effect on our finances, because this is why it's relevant to our finance performance. If we move on to the next slide, please. It made quite a difference in terms of our additional income. So 10.5 million additional income from commissioners. That meant that we added 34.63 additional whole-time equivalent colleagues, and they have dealt with all of that activity that you can see in those bullet points there. So 16,000 telephony contacts a month, around 400 online contacts, 2,500 base appointments a month, and an average of 400 home visits a month. So quite a considerable increase to the activity that we're doing as an organisation. Some of the performance headlines Douglas has already talked about: improved call handling. Call answer times have been getting better in Gloucestershire. We're exceeding on some of the key targets, so performance in emergency departments, as well as checking whether ambulances were required, where ambulances were used, and we're showing really strong system navigation about how patients are signposted or indeed transferred to the right point in the system. And really important that we've improved our callback times for healthcare professionals. Still more to do to meet the national standards. And we're improving the directory of services, which is sometimes known as the DOS, so that we can actually make sure that people get to the right care effectively. But a big impact on our finances, but also a big impact on our organisation in terms of what we're actually delivering. Just moving on from that, I've just got a couple of extra bits to talk about, and that is the appointments of our new external auditors. So particularly governors of the trust will be aware that the external auditors that we previously had, the contract ended. So that was for 24-25. So the accounts that you've already seen, they've been audited by KPMG, but their contract has now ended. We went through a tender process, which the Council of Governors led. We had 3 submissions and had presentations from those, and we appointed Summer Northern Ireland Limited, and that was approved by the Council of Governors in January 25. So when you see next year's annual report and accounts, it will be a different set of auditors because we've changed our auditors. So I just thought that was worth highlighting today. That's it from me. Hopefully I've gone through reasonably speedily, but obviously if there's any questions, I can take them later. Thank you.
Sandra, did you want to just pick up on that slide?
No, sorry, that was just saying that the KPMG have audited the accounts. It obviously it gives people the links to the accounts. I suppose I could say that they issued an unmodified and unqualified opinion, but that's all in the annual report that people, as you said, have already received.
Lovely. Thanks very much, Sandra. So hopefully the strong message that very strong financial management in the trust, which is of course a credit to everybody working in the organisation. So again, reiterate my thanks to all colleagues in the organisation for managing the money well and investing well when we look to spend some of our capital money. So thanks very much, Sandra. So let's pass on to the next presentation. So clearly we've talked about the money, we've had a summary overview from Douglas, but the quality of our services are clearly fundamental to us as an NHS trust. So Nicola Hazel, who's the Director of Nursing Therapies and Quality, is going to lead the presentation. And just to give a special welcome to Nicola, because we mentioned that we've been joined by 3 executive directors during the course of this year, and indeed 3 non-exec directors onto the board as well. So Nicola Hazel is one of those executive directors who joined us in the summer of 2024. So Nicola's had plenty of welcomes, but Nicola, welcome to your first AGM at Gloucestershire Health and Care, and over to you. Thanks.
Thank you, Graham. Nice to see everybody this evening. It is in fact my second AGM because I was here for the one last year, but it's really great to be able to present the work over 24-25. So I'm going to take you through an overview of the quality work that we've undertaken across the trust. Much of what I'm sharing today is included within our quality account for 24-25. So I hope to provide details of what we have done to progress the quality priorities of our quality strategy. And I've also included some other examples of our work that deliver on the 3 pillars of quality, which are effective, experience and safe. Kate, if you can move the slides on. I think I've covered the purpose by talking. Sorry, I didn't ask you to move that on quicker. If we go to the next one, before I get into some of those examples, this is just for everyone just to see our quality strategy at a glance, and our quality priorities originate from this strategy, and it sets out our quality ambitions, our strategic goals and priorities, and the approach that we've been taking to measure our progress. Through our quality strategy, we are making a clear commitment and approach to empowering the people at the heart of our services, and that our colleagues have the freedom, skills, tools and resources to work in partnership with the people we serve to improve and innovate safely towards defined quality goals. If we move on again, that's just a quick summary again of what I've said there, and with that visual. So the next slide just shows you what our regulator, the Care Quality Commission, what our current position is in terms of their ratings regarding us. So this is our Care Quality Commission is our regulator and inspector for health and social care providers in England, and our most recent trust inspection was in 2022, our full trust inspection, and we received an overall rating of good. It is important to recognise that underneath that overall rating there are service-specific ratings. So within those, our physical health, inpatient and all of our community services hold ratings of good, with some of those services rated as outstanding. Across our mental health inpatient services, we have ratings of requires improvement, and our learning disability inpatient service, which is Berkeley House, has a rating of inadequate and has a Section 31 enforcement in place since October 2023. What this means for Berkeley House is that there are certain conditions under which the service continues to operate. What has happened, particularly during 2024 and 25, is a significant amount of improvement work completed by the Berkeley House team in response to that rating and that intervention by Care Quality Commission. And the Care Quality Commission recently undertook a full and comprehensive inspection of the service in July 2025. And we are awaiting the findings of that. So on the next page, I'll start to talk you through some of the work that we've been doing against our quality priorities, of which we have 11. These were identified to be achieved over 2 years, from 2023 to 2025, but we extended them to cover this current year, 2025 to 2026, to align with the timescales of the trust strategy refresh. Many of these priorities are linked to areas of improvement that have been identified by Care Quality Commission inspections, internal audits and review processes, and other regional and national areas of opportunity and priority. So when we look at our priority and our work in tissue viability, our community nursing service have begun a pilot of a new wound care app called Minuteful. That's happening in the Forest of Dean team, and that is about improving identification, management and monitoring of wounds and pressure ulcers. Many of our integrated community nursing teams are also working closely with system colleagues on the National Lower Leg Wound Programme, and we also have a local project here in Gloucestershire that is looking to improve the provision of dressings that we're involved in. In terms of our priority around dementia education, there has been quite significant amounts of engagement with the public during the year, and we've held dementia action events county-wide, most of those in public locations, so that we're really engaging with the public where they are. So those have been examples are in Eastgate Shopping Centre in Gloucestershire in January. Our teams have been outside Stroud Library in February, and we had an event in Tewkesbury in March. And that's been a really positive and important way of raising awareness around dementia, providing education and help, and having helpful conversations for encouraging understanding of the services and how to access them. In relation to our work around falls, a lot of work has happened in relation to awareness raising and education across our teams, and we have really robust local oversight arrangements when falls occur. We see an increase in frailty in our patient population who come into our services. And that means that when we're encouraging mobility as part of their recovery, that is not without risk. So whilst we haven't seen a reduction in the number of falls reported, what we do see is that high reporting of falls is very positive, because it shows our level of transparency when these occur. But what we have seen is, of the total number of falls that have reported, we've seen the percentage of those that are reported as severe harm remaining stable at about 2%. So that's really positive. Our end-of-life care work has really focused on patient-centred decisions, and we've had 2 QI projects running during the year that have supported that. One of those has created a patient and carer leaflet on eating and drinking within end-of-life care, and the other has developed an electronic version of our shared care plan that is used for the expected last days of life. One other thing I just wanted to mention in terms of 2024 is that we're currently analysing our results from the National Audit of Care at the End of Life audit, and that's a national audit, and we've seen some really high compliance across the 13 domains of that audit, and really strong benchmarking against other services nationally, which shows we're providing really good end-of-life care across our inpatient services here in GHC. On the next slide, in relation to our friends and family test, which operates across all of our services, we've seen a slightly lower total number of friends and family test responses in 2024-25 than previous year. But what we have seen is that we've maintained a consistency in the proportion of positive responses, which is at 93%. The area of growth that we've seen is that we've actually expanded our approach so that we can now identify carer, friends and family test feedback, and that is showing an 88% positive response. In our commitment to reducing suicide, we have finalised our safety assessment policy, and that aligns with best practice from NICE, the National Institute of Clinical Excellence, and it also aligns with recent national guidance called Staying Safe from Suicide, which was published in April of this year. What's been really positive is that the work that we've done on this policy has involved input from colleagues at the National Confidential Inquiry into Suicide and Safety in Mental Health, and they've actually externally validated our policy. And so we're looking at starting to roll that out with some staff awareness training planned over this month and next. In relation to our work around reducing restrictive practice, our behavioural support training team have last year developed a certified training programme that replaces our previous courses. So that's called the Positive Approach to Reducing Restrictive Interventions, acronymed to PARI training, and that aims to really support our reducing restrictive practice strategy. What is really positive is that this course has been externally certified against the most up-to-date nationally recognised restraint reduction standards. On our final slide around our quality priorities, in relation to learning disabilities and our training around positive behavioural support plans, we saw 100% training compliance against this training during 2024-25, and by the end of this year, in relation to Oliver McGowan training, we know that we have trained 6,642 GHC staff and primary bank workers on the Tier 1 level training, and 613 staff on Tier 2. So, and that means that there's increased focus and further work, particularly around our Tier 2 training compliance this year, and ensuring that there's good availability of those sessions. As part of our work on implementing SEND across our children's services, our Children and Young People's Directorate have produced a SEND handbook during the year, and also our SEND Health Advisory Service went live in December 2024, and we've seen some really good performance against the statutory timeframes of health reviews completed within 6 weeks. And the service has also received some really positive feedback from patients and carers who have been receiving the service. In early 2024, the Carers Trust, who are the organisation that provide accreditation against the triangle care. Sorry, Bren, I will put that in. Thank you, Sarah, for adding that for me. The Carers Trust reaffirmed our 1st and 2nd star status as in the triangle of care, and they have given us approval to continue to work towards the 3rd star accreditation. And so there is particular work being led by our carers lead across all of our services to continue to strive for that 3-star accreditation. Next slide, please. So the quality ambition that we hold within our quality strategy, as set out earlier, is underpinned by the 3 pillars of quality, which is about being always effective, ensuring great experience, and being consistently safe. So what I've included in the next couple of slides is just some additional examples of where how we have been trying to improve quality against each pillar. Some of these don't easily sit within one pillar. Some of the examples and some of this work may sit across all pillars, but this just allows us to see where we're doing some work against quality in this way. So in the next slide, you can see that as part of being always effective, clinical audit is a really important part of that, where we are auditing and looking at our effectiveness. And this activity during 2024-25 is actually an increase on the activity that we undertook in 2023-24, both in terms of national and local clinical audits. What we do is all of the audits include recommendations in terms of improvement and best practice across the organisation, and so we share that. Some of those align to some of our quality priorities, such as falls prevention, and as I mentioned earlier, the national audit of care at the end of life, as well as mental capacity assessment audits, just to give a few examples. In relation to our work around research and our contribution to research, we registered and improved 19 studies during the year. Most of those predominantly occurred in our mental health services, but it's really pleasing to see that we're a growth in a variety of other areas. So some of these studies were across children's services, workforce, dementia and neurodegenerative diseases, stroke, and health services and delivery research. And that really reflects the work of our research team and others in championing and supporting opportunities for taking part in research. And we are seeing a growing proportion of these studies being led by local teams and by students. The 73 quality improvement initiatives that are being supported by our Quality Improvement Hub are also seen across all parts of our trust and across our operational services. So 8 within our county-wide directorate, 16 across our mental health hospitals and urgent care, 5 across our physical health hospitals and physical health urgent care, 15 in our adult mental health and physical health and community services, 18 in our children's and young people's services, and 11 corporately. So that's a really great spread. Moving on to a great experience. In 2024-25, we received 204 formal complaints. That was an increase on the previous year of 43, but most of these, so 196 of those, were dealt with as early resolution complaints, which is really promising. Really good to see. As in previous years, we see the number of compliments that received across our clinical services far outweigh complaints and concerns, and we received 2,377 compliments in total. The non-executive director quality visits are really valuable opportunities for ward-to-board connectivity and reciprocal feedback. These complement other internal and external opportunities that we have to hear about experiences across our services. So that includes Health Watch visits, Care Quality Commission, Mental Health Act visits, and the internal programme of peer visits and team self-assessments that we run ourselves. We've seen a further increase in the year in relation to the number of colleagues that are using our Freedom to Speak Up service. And Sonia Piercy, our Guardian, is supporting a large number of champions across the organisation. And analysis of the themes and the experience shows that there is still always more to do in this area, and there is a clear improvement plan to support that. What has been positive is that we've introduced a Freedom to Speak Up app as an in-house application to expand the routes for colleagues to raise their concerns in a safe, anonymous and confidential way. And we also have a route to raising concerns called Director Douglas. And that's a way for any colleague to raise a concern or question directly to our Chief Executive. My final slide is around being consistently safe. So of all of the patient safety incidents that were reported in 2024-25, 22 of those went on to have a detailed further investigation, and we do that either through a care review or a patient safety incident investigation. One of those was also a thematic review. Our patient safety team and our assurance team then do a lot of work in terms of the learning that comes out of those reviews, our complaints and other sources of feedback and learning to support clinical services with sessions that really help to focus learning and improvement. So our assurance team use face-to-face clinical team meetings to do this. We also have patient safety notice boards across 44 areas of the trust with plans to continue to improve those next year. And we regularly communicate out learning on a page in order to share learning from one service and one part of the organisation across to other parts of the organisation. And we see these as a real opportunity to share good practice and help learning and development across teams to ensure it reflects practice experiences. I just wanted to note that our annual infection prevention control report that is soon to be published for 2024-25 really does show the breadth of work undertaken by all services across the trust, and the low rates of infection that you'll see in that report when it is published is a real testament to all the hard work and commitment that is done by all across the trust. And then finally, our Learning from Deaths report shows that our and the feedback from the Medical Examiner Service, which is a national system that provides independent scrutiny of deaths which are not subject to an inquest, is a real opportunity. We've had regular feedback provided by the Medical Examiner Service to the Trust from families, and this continues to provide significant assurance that the care we're providing to our inpatients at the time of their death was of a good standard. And that is my quality update.
Thanks very much, Nicola. And there may be questions at the end coming back from that, but really appreciate that. And again, further information in the annual report and accounts, which is accessible on our website. So just move on to the final contribution before we can take some questions. So as a foundation trust, we have members, and if you live in Gloucestershire, then you can be a member of Gloucestershire Health and Care NHS Foundation Trust. One of the important roles of the members is to elect governors. And governors have two main jobs. One is to hold non-executive directors to account, make sure that we're doing the right role in terms of how we're operating, holding executive directors to account. So something about making sure that there's accountability in the trust. And then the second one, as I mentioned earlier in my opening comments, is governors providing important links and connections to the various communities that we serve. Chris Witham is the lead governor amongst the governors, and sadly Chris is not able to join us in person for the AGM, but has taken time to record this update, which we'll hear from Chris about the work of the Council of Governors. So if it's ready to play, let's hear from Chris Witham, lead governor.
Good evening, everyone. I'm so sorry I can't be there with you in person this evening. I've had to travel to Birmingham as part of my role in the NHS. But I'm so glad to be able to give this report this evening on the work of the Council of Governors. All foundation trusts, like our own, have a membership body, and that comprises members of the public and staff members. And that membership elects people to represent them on the Council of Governors. We have both public and staff governors, and we also have some nominated governors representing specific partner organisations. The role of the Council of Governors is primarily to hold the non-executive directors to account, and that's for the performance of the board and the organisation overall. We represent the interests of all the trust stakeholders in the governance of that organisation, And we have a really important role in communicating key messages from the Trust out to the electorate and the citizens we serve. The Council of Governors, as I said, is made up of public, staff and appointed governors. We've currently got 13 public governors across 7 constituencies, 7 staff governors in 3 different classes, and 4 appointed governors representing Gloucestershire County Council, Young Gloucestershire, Healthwatch Gloucestershire and Inclusion Gloucestershire. And also our Trust Chair, Graham, forms an important member of the Council of Governors. At the end of 2024-25, we had a membership totaling 8,106 members. And you can see the breakdown on public and staff members and the different constituencies on the slides. Across the previous year, we had 6 formal council meetings, and we also had 2 excellent governor development sessions. The first one we used to get to know new governors and each other better after we had quite a few new governors join us. And we also looked at the quality improvement programme that the Trust uses. The second session earlier this year was a joint session with governors and the non-executive directors, focusing on the various aspects of our roles and ensuring that we have good governance and relationships across the piece. And this was an externally facilitated session led by NHS providers as part of their Govern Well training programme. Some of my favourite parts of being a governor are the service visits we get to do, and this year we've been able to really refresh the visiting schedule and make much more of that opportunity. And you can see some photos on the slides of governors making different visits to our various services and facilities. We've carried out a Governor Ways of Working review, looking at how we optimise the contribution and value that governors bring to the organisation and the various ways we can appropriately get involved in the governance and improvement of the organisation. We continue to receive a monthly schedule of trust engagement events, and governors support a wide variety of events across the organisation. I've been very fortunate myself to visit Cirencester Hospital, the Forest of Dean Hospital, along with our musculoskeletal services in Stroud and colleagues who work at Edward Jenner Court. And it's really fantastic to see all the ways that we serve our county and the people who live here. Governors are also represent our organisation at different forums and conferences and workshops that are run by NHS providers across the nation. This year we've continued to receive the Governor Dashboard, which provides us a great deal of information about how the organisation is performing against different quality measures. We've held a dedicated session focusing on the NHS staff survey results and looking at how we continue to make our organisation a great place to work. We've received and commented on the Trust Quality Account, and we've received service focused presentations from areas across the Trust highlighting the great work that goes on here. One of the less glamorous but very important parts of the governor role is approving the appointment of our external auditors, and we've overseen the external audit tender process as we've appointed a new auditor from the start of April. We've also, as part of the Nominations and Remuneration Committee, overseeing the appointment of new executive directors, received and endorsed recommendations about the proposed recruitment process for future non-executive directors, and approved the remuneration increase for non-executive directors, and approved the reappointment of an existing non-executive director. I think it's really important to highlight that our Governor dashboard has received national recognition, and the Trust were invited to present a case study at the 2025 NHS Providers National Governor Conference in June. And a lot of credit needs to go to Anna Hilditch for all her hard work on developing and revising and producing the Governor dashboard, along with all the other colleagues who contribute to that. It really is an excellent piece of work and really helps governors to do our role well. Thank you, Anna. Looking to the year ahead, we'll continue to seek assurances around trust performance and delivery. We'll continue to enhance our membership strategies, and I thank Kate Nelms and her communications team for the work they've put in to support us in doing that. We'll continue to build and strengthen our ways of working, and we'll continue to promote governor attendance at local and national events. I'm sorry I can't be here, as I said, but if you do have any questions about the governors, I'm sure there are other governors on the call willing to answer those questions, or I'm very happy to be contacted by email. Before I go, I'd like to say a huge thank you to all of our staff and volunteers who work tirelessly to make this organisation the organisation it is, and to provide great care to our patients and citizens across the county. Without our staff and volunteers, we wouldn't be the organisation we were, and many people wouldn't receive the level of care that they receive. As a patient of the Trust, I've been fortunate to receive excellent healthcare in an excellent setting, and that is all down to the dedication and hard work of colleagues across the organisation. A huge thank you to all of us. Thank you for all you do. Good night.
Well, thank you, Chris, and the opportunity for me as well to reiterate the thanks which I gave in my opening comments to Chris as the lead governor, and indeed to all governors who literally are the foundations of the Trust, and hence we are Gloucestershire Health and Care NHS Foundation Trust. So massive thanks to all governors, many of whom are on this call. And because governors have a fixed term of appointment, there is always people joining and people leaving at the end of their term. So if you know anybody that would be interested in being a governor over the next year or two, then please make that opportunity available and aware to people that you might know in the community. So thank you for that. So let's go on to some questions then. So we've had a lot of contributions there to tell you about the performance of the Trust during the year. We were really pleased to get some questions issued in advance. All those questions will receive an answer, and as indeed questions in the chat. We won't be able to cover all questions. But what I'm going to suggest is that because we did have some pre-questions received, we'll take just 2 or 3 of those, and then we'll go on to electronic hands. And I can see that welcome to Bren, whose hand has gone up. But we'll take, first of all, just take 2 or 3 of the questions that were sent to us in advance. So the first one, Rosanna, will be one of the ones if you're there and ready. So Rosanna James is the Director of Improvement and Partnerships. And Rosanna is just going to remind us of a question and the answer to that question from Valerie Sims, who has actually reiterated the question and indeed one other in the chat that we've gone through. So Rosanna, if you're there, pass over to you in terms of the question and answer that we can provide to Valerie Sims. Thank you.
Yeah, sure. So good evening, everybody. Rosanna James, Director of Improvement and Partnerships, and I'll read out Valerie's question just so everybody knows what it is. So that was, how is Gloucestershire Healthcare ensuring that young people from underrepresented and diverse communities are included in future wellbeing and mental health strategies? What opportunities exist for community organisations like ours to access NHS health partnerships or capital support to make spaces more inclusive and health focused? And Valerie is from Open Doors for You, a CIO, and Walk in My Shoes. So First of all, Valerie, thank you very much. I can see you're on the call. We have run this question by our children and young people's inclusion lead that sits in the partnership team under my own portfolio. What we just wanted to say, this sounds like a partnership we'd like to nourish. So afterwards, I'd love to put you in contact with our lead, Josh. And his job is to give children and young people from all walks of life the platform to impact the services affecting them. This programme of work internally we call Youth Voice, and it has two strands. The first is Youth Experts by Experience, and this is a group of young people that have often been through NHS services. They're passionate about using their experience to create positive change. Currently, it does change, as you can imagine, people leave and people join, but currently this is a group of 21 young people that meet twice a month. We discuss topics with an NHS staff member from a different service each time. And some of the topics this year have included, for example, how do we hold honest and open conversations with young people and family members in a therapeutic setting? Another example, how can we make the reception room in one of our facilities, Aiken House, more comfortable for children and young people? And the group has supported in separate projects to date this year and continue to support a range of services. Second main strand under Josh's remit is Youth Voice, and Josh co-chairs a Children and Young People's Participating Committee of Practice that brings together statutory and VCS organisations that work with youth participation space or impact the services they use. Membership of this group is open to anyone, and that would identify in this space, and we currently have over 20 organisations attending meetings about every 6 weeks. So we're really keen that we could explore that potential opportunity with you, and we'll pick up later. And as well as the roles I've just described, Josh does always looking for new opportunities. So we've got some new partnership working with specialist schools provisions, a programme called we look at called Young Mind Matters in schools, helping to connect mental health services in the education setting, and creating a working together collective, a working group of clinical staff to wrap around our Youth Voice programme to turn voice into action. So look forward to connecting with you offline, and hopefully that answers the question.
Thank you, Rosanna. Douglas, we've had a question from Peter Stenton, guest, and maybe I could maybe ask you to sort of remind us of the question, or let us know the question that's coming in and the response. So as a reminder, Douglas Blair, Chief Executive of the Trust. Thank you.
Yes, thank you. And Rosanna, your signal's going in and out slightly. I think we all kept up with it, but occasionally it sounded like you'd just been to the dentist. But it came in and out slightly. But I'll do the. So Peter, thank you for your question. It was, what is the next most important change or changes you would like to see achievable that at this point is not quite there? And what would be needed for that to happen? And do you see a way forward to achieve that aim in the coming years? So quite a broad question. Thanks, Peter. But I think the thing that I mentioned in the overview was some of the work we've been doing the last few months in terms of that kind of strategy, setting out our aims for the next while. What we've been quite deliberate about trying to do this time around is still keeping true to some of our high level aims, but also trying to set out a few more clear areas of focus. So the one that I would pick from there is actually, in terms of your question, made me think about was some of the work that we've got to focus about that neighbourhood NHS kind of national policy, in which it's an important change. It's an important change across the country, but also it's one we'd probably say as a whole county, it's not one that we're quite there yet. Lots of good work's happened across with primary care, with others, but also how we work together with partners and how we make it more of an organising principle about how local we can make both our services, how they keep local wherever possible, but also how we also make sure that the way that we deliver care across the whole NHS is not as reliant on big hospitals, lots of appointments and other things, how we kind of wrap around primary care and think about supporting people over the longer term. So there's lots to do there. It's a big national priority and something I think would set in your context of things that are not quite there yet, things we need to focus on over the next few years. For those to be true, the second part of your question, I think it is all about partnership. It's working across with others, not saying that Gloucestershire Health and Care can do it all on our own, but I think we've got a really important role to play as well. Could have picked a range of different things, but your question brought to mind that area in particular. And as Lavinia says in the chat, all the questions we received, we've just picked a selection to kind of get us going here, but all the questions we received will get a full written response. So thank you very much for the questions that come in.
Thank you, Douglas. Rosanna, if your signal's holding up, maybe come back to you for a question that we received in advance from Erin Murray. So again, if you could, we might let us know the question and the response. Thank you.
Sure. Can I just check? Does that sound like my sound's okay?
Yeah, I can hear you. Thank you.
Okay, lovely. Right. So this question was from Erin Murray, who is from GL11 Community Hub, a voluntary sector organisation within Gloucestershire. Her question was, as a VCSE, we would like to hear more about the NHS initiative around neighbourhood care, care in the community, and how this will be resourced, funded and trained and training extended for community-based organisations. I don't think Erin's on the call, but to respond, the NHS 10-year plan, which is called Fit for the Future, has community neighbourhood working as one of its three shifts, which are hospital communities, analogue to digital, and sickness to prevention. And there's been some corresponding health guidance released, which defines 6 core components of neighbourhood health, designed to help commissioners, health and care providers, and including VCS organisations and local authorities with the transformation that is intended. It's a framework for action, the 6 core components that are tailored to meet local need, and they are designed to help systems decide what makes an effective neighbourhood health service. Briefly, those 6 components are population health management, modern general practice, community health services, neighbourhood multidisciplinary teams, and integrated intermediate care and urgent neighbourhood services. So the good news is that in Gloucestershire, work is already happening around neighbourhood health. We have for a history of delivering at primary care network level, and I'll just explain what that is. So that's typically a population of about 30 to 50,000 people based around general practice services and what's registered on their list. We've already developed integrated multidisciplinary neighbourhood teams for frailty, and our focus on frailty has been given has largely been determined from what we know about our demographic pressures that we're going to face in the county. So a quick stat for you, there will be, it's projected, a 52% growth in those aged over 65 in our county by 2043. So hence why we've had that focus on frailty. And what do the teams do? Just to give you a bit of an insight, using public health management tools, including risk stratification, teams assess those most at risk of admission or deteriorating of health, and they intervene early to support their health needs, linking with some of our services as well as general practice, and also addressing their wider needs, signposting people to dementia groups or activities, balance classes, for example, some of which may be provided right in their community and indeed by the voluntary sector. For GHC ourselves, some of our teams won't work at that 30 to 50,000 population. They'll work at a different level on a larger footprint because of the numbers of teams that we have over larger geographies, maybe on 100,000, but that would be sort of our mental health services. So in response to Erin's question, how could our strategy, how will this be evolved? How will it be delivered and developed with communities in the voluntary sector? The plan will sit under the Gloucestershire Health and Wellbeing Board, which does involve voluntary sector reps as well as local authorities and health partners, design this together. There isn't any dedicated central funding that's been passed down this year for the development of neighbourhood working, and how this will be resourced and funded, or indeed, to Erin's point of how training will be extended to community-based organisations, would be part of our ongoing discussions on One Gloucestershire funding and conversations. So very much look forward to working with partners, including the VCS, under the guise of the Health and Wellbeing Board and Partnership, because we do understand that these are really critical components of neighbourhood health.
Thank you, Rosanna. And I think it's timely for me, on behalf of all of the Trust, to recognise the fantastic value and contribution of the voluntary sector across Gloucestershire. As I mentioned in my opening comments, you know, we really value and welcome the partnerships that we have with the voluntary and community sector. And in our new strategy, we'll be looking to further develop those, because working together, we can get so far, we can get further rather than where we can get on our own. So massive thanks to Erin and everybody else that involved in the third sector, voluntary sector in Gloucestershire. So massive thank you. Douglas, they're the questions that we've selected from the pre-questions. I wonder whether you'd be willing just to call in one or two questions before the close of the meeting at 6:30, and also leave you then to direct who might be best placed to answer them. So thank you.
Yeah, thank you. So Brian, you've been very patient with your hand up. Thank you for being so. So do you want to just come in with your question?
Yeah, thanks, Douglas. I haven't been called patient for a long time, but I try and best. Look, before I begin with my question, and very briefly, I'd just like to say thank you to everyone in the Trust for all you do. Thank you for all you do that we don't see that you do, but makes that massive difference, really. So thank you very much to everyone, really. So my question / comment that will lead into a question is around communication. And I think that the Trust can do better at communicating back once people have communicated in. So I want to put this in a real example. So there were 2,000 people from diverse communities, an event led by the Bangladeshi community. I sent an email in to say, look, you know, we're looking to do this, the opportunity for the Trust. I got zero communication back. And for me, then, as some of the people said, is that how they value us, Bren? So there's something about, not only when people take the time to email in and communicate in, is let's actually at least send a thank you. I'll leave it at that. Second point to the question, though, really is Douglas, how do you feel where the culture of the organisation is now, and what measures would you or the team use to say that's the assurance we've got, that we've got a good, a fair and a just culture? Thank you.
Thank you, Brent. Thank you. So the first question, apologies if you didn't get a response. Obviously, really keen to be part of different events, different opportunities. Obviously, we need to plan that a bit in advance in terms of people knowing about them, whatever. So apologies if we haven't got back to you particularly on that, but shouldn't be seen as a disinclination to be part of any opportunity to speak with broader communities. So apologies for that. On the second question, I think the honest answer to that, Brian, is that the culture of the organisation is something we always need to pay attention to all the time. I don't think there's a fixed point in time which we would then say, this is what we think we are, this is everything that's done. It's something we're ongoing. As I mentioned in my presentation, we're really clear, and we've tested this, that there is good recognition of those values. So that's a first indication that are we setting out clear values and expectations, and are they being seen and well recognised and well embedded? So that's the first indication I'd look to. I think the second indication is how are we then dealing with any issues where we think people are not exhibiting those values? How are we using both in terms of feedback? We've got plenty, and Nicola set this out in her presentation, we've got plenty of routes for people to raise concerns, raise issues. She mentioned freedom to speak up processes. We've got open forums that happen every month. We've got a Direct to Douglas app, so I directly get messages and concerns from colleagues about different issues as well, and they all get responded to. So again, have we got those feedback loops? Have we got an ongoing conversation as well? Thirdly, I'd look to, and what happens then if we think that people are outside those values? Are we using our disciplinary processes as necessary? Are we doing that? And again, that's ongoing check. We're doing further work in terms of how can we improve those? How can we make sure that we're doing all that as well? So again, I don't think I can say simply, oh, we've got fantastic culture, everything's going to be perfect, of course, because you wouldn't expect that from us. But I can say we've got good, strong values, well recognised, and we're ongoing conversations. We've got an internal leadership and culture programme that we've been doing, an exploratory kind of how much more, how can we get better, how can we do even more as well. So it's something we're paying attention to all the time, and we'll never stand still on that. So hopefully that gives you some of that assurance from that point of view.
Thank you.
Okay.
Just a couple of minutes left, Douglas.
Yeah,
so
exactly.
You may have time for one more.
So Bob, I'll just bring you in.
Thank you very much. Yeah, I do understand we've got 2 minutes. So I'm not expecting a full answer to the question. Before I ask the question, I just wanted to say that, I mean, having read the annual report, what a really good and positive read it was, and it was good to see the challenges in that report as well as you highlighting the positive points as well, and that's really important in a report like that. The question I have arises really out of a visit, a really successful visit, I think, that myself and some governors and one of the NEDs took to Wootton Lawn this morning. It was very enlightening, very, very positive feedback from the staff, particularly about staffing levels, which have been difficult in the past, and there was a real positive vibe about those being sorted out. One of the big issues that they have, though, and they're really strong about highlighting this, was the issues that the challenges they have with complex emotional needs patients, which they say is not really catered for and not really budgeted for within the trust. So I think, you know, not really for now, although, you know, I'd like to hear your initial thoughts. But, you know, can we look at that in the coming year, and can we try and help them out with that? Because it was a really, really difficult issue for them.
Okay, thanks, Bob. Good to hear we've been visiting. I'm going to actually see whether Sarah Branton, our Chief Operating Officer, just wants to give us a very brief kind of 30-second answer, which probably won't do justice to your question, Bob. So very happy to continue the conversation.
My goodness, Bob, Douglas has asked me to keep to 30 seconds, which is almost impossible for me on this subject. So I'm really happy to pick it up afterwards. I think you're absolutely right. I think it's this is a group of people with incredibly complex needs, and us working out the right pathway for them, how we provide the right intervention as early as possible and in the right way to make sure that we're really supporting and understanding what it is people need, what is leading to people needing support, and actually how we provide for that is really important. I'm not surprised that you would pick that up from a psychiatric hospital, because actually often the group of people that would come under that definition, a psychiatric hospital is not always the best place for them, and actually can cause more difficulties for them, and it is really, really tricky to provide the support in that environment. So what we need to do, and what we are working through, is actually what's our clinical model, what's our model of care and intervention to provide for those people with that level of need, both in community services and understanding what it is we should offer in a psychiatric inpatient environment. But I'm happy to pick up that with you more if that would be helpful.
Yeah, and I think one of the thoughts was that if we can tackle it in the community before it gets to hospital, and you know, that's
absolutely
that's the solution, isn't it?
Absolutely.
Yes. Thank you very much, Bob, for your question. Lots more discussion we can have. Thank you for everyone's engagement from questions and both pre and in this session itself. I'll hand back to Graham.
Great, thanks very much. Thanks for the questions and the points raised. And I guess, Bren, I won't reopen your question, but that lands right into our value of always improving. So we'll happily take sometime the kick on the shin pad, but with a view that we will be better and always improve. So thank you. So as Bob has just said, Bob is a governor for the trust. 2024-25 has been a positive year for Gloucestershire Health and Care NHS Foundation Trust. And I said earlier in my opening comments that that's a year gone now, and we are where we are and the future we look to. So my sort of comments, a couple of comments I'll leave with you. So the annual report and accounts that we've shared this evening provides the springboard for us to shape our new strategy, which we'll be launching soon, and we've mentioned previously. And thanks to everyone who's played a part in shaping the new strategy. There are a number of organisations, individuals, colleagues that have been part in shaping that strategy. It's been absolutely phenomenal, and we can share those numbers with anybody that's interested to know. It's been really a collective effort, both within the trust and beyond the trust, to shape that new strategy. Second thing about the year we've been hearing about, provides the impetus to embrace the new NHS 10-year plan, which again, as we've heard through the evening, advocates a shift to providing healthcare in the neighbourhoods where people live, and to place a greater emphasis on prevention rather than treatment. And thirdly, it provides the year just that we've been talking about, provides us with the ambition to be the best we can for the people of Gloucestershire. So we look forward, as well as looking to that past year, and we look forward to working with all of you on this call and other people that weren't an organisation but able to join us. Thank you for being part of the AGM this evening, and have a good evening. Thank you.